let's get started. Hello, everyone. Welcome to today's Appeal webinar, Building Equity, Creating Change from Within Health Systems, brought to you by the Aspire Network. It's August 24th, 2023, 11 a.m. Pacific time. My name is Michelle Ju, Program Coordinator of the Aspire program at Asian Pacific Partners for Empowerment, Advocacy, and Leadership, also known as Appeal. I'm your host, and I'll be introducing today's speakers. Today's speakers will discuss advocacy, engagement, and partnerships in terms of policy change. Our speakers are Vayong Moua and Ladine Chan. Join us as we discuss approaches to embedding equity-focused organizational change and policy strategies for commercial tobacco that affect special populations. The purpose of this webinar is to provide guidance on building infrastructure to support adopting and embedding equitable organizational policy change for tobacco and tobacco-related cancer control and health departments, healthcare organizations, national nonprofit organizations, and community partners. Before we begin, I would like to provide some quick information about our organization. Appeal is a national nonprofit working to advance health equity and social justice to all, and to eliminate tobacco and cancer health-related disparities in Asian American, Native Hawaiian, and Pacific Islander communities. Appeal implements the Aspire Network, one of 8 CDC national networks jointly funded by CDC's Office on Smoking and Health and Division of Cancer Prevention and Control. CDC's national network approach to preventing and controlling tobacco-related cancers in special populations. We aim to build community capacity and facilitate the development of tobacco, cancer, and disease control equity policy initiatives among diverse AA, NH, and PI populations. We provide training and technical assistance and resources to all communities and tools to help organizations reduce tobacco use and cancer among our priority populations. And we facilitate opportunities to engage in policy systems and environmental change activities. Next slide. So remember our communities through the faces of the people we work with. And here's an example of some of the communities that we do work with. Next slide. At this time, I'd like for us to take a moment in light of the tragedies around the nation, including hurricanes, storms, flooding, fires, violence, and especially most recently among our friends, colleagues, and communities of Maui and Greater Hawaii, Ohana, following the deadly fire disasters in the past few weeks. So please join us to support our networks and partners who have stepped up to support the affected Native Hawaiian and Pacific Islander communities. The support and outreach for the Maui community during this time of recovery has moved us all. We strongly encourage the public to support organizations trusted by the community to ensure funds reach those in need. For example, please consider the Council for Native Hawaiian Advancement Kaka'o Maui Fund. They provide resources that can be deployed quickly and efficiently to our Hawaiian communities impacted by the Maui wildfires as one of the on-island efforts. Okay, next slide. Thank you. We will now begin our webinar. The webinar objectives are as follows: how to implement policy change that addresses tobacco equity issues at different levels of an organization and systems, build power through organizational leadership, authority, community engagement, and collaboration, how organizations leverage community partnerships for success in tobacco control, and building capacity, strategies, and resources to help with organizational policy change to support equitable solutions. Next slide. The agenda is as follows: introduction of the webinar, which I just did, housekeeping, presentation by Vayong and presentation by Ladine, and then panel discussion with the Q&A pieces, and finally closing, which includes our survey piece. So webinar housekeeping is as follows. Next slide. This is a webinar format Zoom call. Your video and mic is off throughout the entire webinar. Please ask your questions for the speakers by clicking the Q&A icon on the bottom and then clicking to all panelists and attendees. If you have any other questions to the speakers, please drop those in the chat box. If you have any technical questions, our technical support team, Josh and myself, are on this call to help you. Please chat us if you need us. The webinar will be recorded and will be posted on our designated program websites for participants to view once the recording is finalized. Thank you for your cooperation in making this a great webinar for all of us, the speakers and the community. Next slide. And finally, I'd like to introduce our featured panelists. We have some great speakers here for you today. First up, we have Vayong Moua, with MPA, Director of Racial and Health Equity Advocacy, Blue Cross Blue Shield of Minnesota. Vayong leads advocacy to advance racial and health equity, RHE, in policies and structural determinants of health. His philosophy and action focus on integrating RHE equity into governance across sectors, issues, and cultural communities. Moua applies cross-cultural power and equity analysis into advocacy approaches, community engagement, and upstream solutions. He has worked on a myriad of COVID-19 equity, commercial tobacco control, healthy food systems, community design, and cultural leadership issues. Moua has championed Blue Cross's Health in All Policies investment and co-founded the Minnesota Complete Streets Coalition that led passage of Minnesota's state Complete Streets law. He's chaired the Legislated Cultural and Ethnic Communities Leadership Council from 2015 to 2019, and this catalyzed the Department of Human Services agency-wide policy on equity. Currently, he's the first chair of Blue Cross and Blue Shield Association's Health Equity and Public Policy Work Group. At CBSMN, Moua leads Racism as Public Health Crisis and our racial equity and policy-making efforts. He received his BA with a triple major in philosophy, sociology, anthropology, and Asian studies from St. Olaf College, and an MPA from the Robert M. La Follette School of Public Affairs at the University of Wisconsin-Madison. He was a Public Policy International Affairs Fellow, Humphrey Policy Fellow, and Bush Fellow. Outside of work, you'll find him outdoors, disc golfing, fishing, one-wheeling, and snowboarding with his loved ones. He celebrates his Hmong refugee identity, and along with his wife, Pachia, enjoys raising Ishi and Ishua, 7 and 3. Next slide. And next we have Ladine Chan. He's the Program Manager, Youth Health Development, Families and Good Health. Ladine is a 1.5 generation Cambodian American and was raised in Long Beach, California. Today, he serves as the Program Manager at St. Mary's Medical Center and Families in Good Health. He manages the Youth Development and Chronic Health Prevention Program. Ladine brings over 20 years of experience working with low-income communities of color to focus on youth engagement, tobacco prevention, social justice, and policy change. He received his Bachelor of Arts in Sociology at California State University, Dominguez Hills. All right, so at this time, I'd like to pass over the presentation to Vayong, and he'll let you kind of lay out all the different pieces for organizational policy. All right, Vayong, take it away.
Thank you, Michelle, and thank you to Appeal for hosting and for prioritizing such an important topic. It's great to always reconnect. I feel like I'm with family when I'm with Appeal, and so thank you for creating this space. Just a fair warning to you all. Michelle mentioned I have a philosophy background, and so I tend to meander and weave in existential things as well as public policy things. So please, Michelle, please keep me on track and keep me focused. I come from an oral tradition, and so I have slides, but I plan to use it mostly as background and plan to zigzag around a little bit. And for the audience, if you have questions, please put it in the chat or just chime in. I'm very open to just taking things on the fly as well. Can you all see this slide here? I just want to double check. I'm trying to share my screen. Can you see this?
Not
yet. I think Michelle, you may need to disable something on your end. It says host disabled participant screen sharing. So I don't know if if you need to do something on your end too.
If you can make him a co-host, Michelle, that will get
Excellent.
him. There you go.
Just give me a thumbs up or just verbal confirmation when you can see these screens if you can. If not, I in the meantime I can just jump right in. I just want to maybe begin with kind of broad and the highest level epiphanies, since sometimes in these conversations we drill down into technical aspects, and I think we all know that advancing racial and health equity is not a technical issue. We all know that this is not just about changing a procedure or changing a certain policy, and so I just want to make sure that I can begin with kind of this broader recognition. So is this slide on my end or your end, Joshua? I just want
to. That's on my end.
Okay. All right. Why don't you just go to the next slide, and then I just want to always ground my talks, my presentations with my own origin story and connect the personal to the policy. And this is a picture of my family arriving in Eau Claire, Wisconsin. We are the first Hmong family there, and I'm the child being held by my mom. And flash forward 25 years, my mom worked in Eau Claire Public Health Department as a community health worker. My father worked on civic engagement in the mayor's office, and I often say that I am my career has been forged between civic engagement and public health, but all kind of threaded with a sense of racial and intersectional justice. Next. And so before jumping into kind of like the importance of policy development and implementation, I just wanted to state these kind of key epiphanies for me up front. I won't dig into each of them, but I just want to make sure that what we're discussing here is much bigger than just an organizational policy, right? And I think it's important to recognize that as we try to tackle these inequities, whether it's in diabetes or COVID-19 or commercial tobacco use, I think it's always important for us to recognize that these inequities are preventable and that they're unjust. And sometimes in the effort to eradicate them, it can seem overwhelming. And especially when you look at the social determinants of health, it just seems so powerful and overwhelming. And that I think we need to remind ourselves that these inequities were engineered by design. And as such, they can be, in recognizing that they're human created by decision makers, we have the opportunity and responsibility to address them. The other big epiphany here I just want to really name is that structural problems really require structural solutions. And for so long, we've been mismatched. We've been throwing programmatic solutions or funding solution to a structural problem, or a service issue solution to a structural problem. And I think we're going to need all levels all the time. And that those levels are personal, interpersonal, organizational, community, structural, a real ecological approach to this. Next. I know this quote is well known, and it's I know this audience knows this very well, but I just want to remind us of the power of the industry and how racist this industry has been throughout its history. And so I just want to make sure that we recognize the degree of organized, well-financed, politically savvy opposition at play here. I'm from Minnesota, and I know that they spend $10 million a year just on a day. I'm sorry, $10 million a day just on advertising here in Minnesota. There are 47 lobbyists registered in St. Paul from the tobacco industry. And just to give you a sense of scale, Blue Cross and Blue Shield, we were not part of the master settlement. We were co-plaintiffs with the state of Minnesota, and we settled for $250 million. And so my department is solely funded from that. And in my view, that's blood money, right? And even though it's $241 million, that's nothing. That's chump change compared to what the industry has. Next. So I know all that is profoundly obvious to this group. You are from health departments. You are from community groups that fight the good fight. But I just want to make sure we have that good reminder. I already touched upon this. I just think it's really important that we create multiple portals into the movement, and whether you come from this from a structural standpoint or from a personal standpoint, I think it's important to link each of these levels to make sure that we're not remiss in having that compound impact. Next. You can go next, Joshua. Yeah. Before getting to the heart of my talk, which is around policy creation and implementation, I want to talk about an inequity that often is overlooked. And to me, when we question how do these inequities occur, and this is a Minnesota-specific poll, we wanted to get a better sense of how the public prioritizes racism as a public health crisis. And to me, this is really indicative of why we have these inequities. If you could extrapolate these sentiments, public sentiments, into investments, into hiring practices, into philanthropy, into policies. And so if you see this kind of discrepancy between those that are experiencing racism and those who candidly are part of perpetuating that, and then you do the power overlay of decision making, funding decisions, and it's easy to understand how these inequities are created and engineered. Next. And then kind of, I know there are many folks here from state and county and maybe even city health departments, maybe even some tribes here. I'm not sure, but I just wanted to recognize that in our polling, there was strong support for having state agencies embed racial equity issues into their policies, into their budgets and programs. There's an understanding that if we're serious about this, that priority has to show up in our human, financial, and political capital. Next. This is just a resource if folks want to learn more about structural change and competence. You can visit these sites at your leisure. Next. So this may be an oversimplification, but if we're always asking like how do we address these inequities, and then we recognize that they're political and policy determinants of health, how then do we tackle that? And I think one key approach is to make sure that we embed RHE, racial and health equity, into governance, into the policymaking process itself. And certainly, I think it's more for us to apply RHE to commercial tobacco control or COVID or food insecurity or transportation, all these issues. We should apply to that. But I think at the heart of what we're trying to address here has been an inequity in power, right? In the distribution of resources, in decision-making, in discretion over what matters. And so this is a broad template, I think, about making sure we are seeding RHE principles, criterion, and practice in the heart of policymaking itself. So that's the crux of what we're trying to do here in Minnesota, to make sure that it is part of our governance and not just applied to a service, to an issue, or to a specific program. And so we're really trying to map out like where does power lie, who are the decision makers, and make sure that RHE is embedded in that set of source of power. Next. These are examples. I'm going to pass through the slide quickly, but I just want to give you an example of how in Minnesota we've been trying to anchor racial and health equity into public policy, into organizational policies, and specifically into our Department of Human Services, and Department of Health. And these links will give you a sense of how we made sure that these councils made up of different cultural and ethnic communities are built into legislation, and not just a token group, not just a rubber stamp, hey, good advice, take it or leave it, but we're making sure that we have membership from cross-cultural communities, as well as anchored in um, uh, political authority. Next. And this is the legislation that seeded the creation of the Cultural and Ethnic Communities Leadership Council. And so I just think it's really important that even if you are an so-called insider and you work within a health department, that you have strong, deep, authentic relationships with communities experiencing inequities. And that can't just be only based on kind of report, but it has to be rooted in some kind of policy cover and authority to make sure it's locked in place. That's not contingent only on the goodwill and good connections and chemistry between the people there. Next. Michelle, help me keep on track. I want to cruise into kind of this slide. Okay, great. So I know that a lot of what Michelle and Appeal asked me today was to talk about how can organizations, whether you're a health plan, we're the largest insurer in Minnesota, or a health department, or a foundation, or a small nonprofit, how can you actually institutionalize the practice of racial health equity? And I think many of us are guilty of trying to advance policy change in community at city council, at the county, at the legislature, but we may not actually operationalize it within our own organizations. And this is beyond your typical DEI work, right? This is not just about changing the composition of your staff or of your team. This is about changing power dynamics. This is about changing the way you make decisions. And so in Minnesota, and with my work with the Department of Human Services, which is the largest state agency in Minnesota, this is a state agency that covers approximately 45% of our state budget. Covers everything from mental health to food security to public health insurance. And so in my work with DHS, we consistently came across this problem of like reviewing and applying equity to, say, an RFP, or to one research methodology, or to one contract. And it was like it's like playing whack-a-mole, right? We're never catching up to the root problems. And so the recommendations that the Cultural and Ethnic Communities Leadership Council, which I was fortunate enough to chair, we came up with was to have the commissioner of DHS, along with her executive leadership team, to develop a comprehensive equity policy that would cover contracting, procurement, policy analysis, community engagement, research, all the kind of key elements of an organization's functions. And then to make sure that equity, we were very clear that equity had to be explicit, but not exclusively focused on racial equity. That it had to be intersectional as well. And so not only did we have these various areas of coverage, we pushed for the creation of positions for equity directors for each department, so that this policy had teeth, accountability, it had funding, it had oversight, it had connections to the legislature, and frequent reporting. So there are a lot of mechanisms you can create to ensure praise, visibility, accountability for the policy. But I want to make sure that you saw kind of the key components here, because this isn't just about equity and just in a funding stream or in just recruitment or hiring, but we were really deliberate about making sure we went to the heart of the organization's core functions. We can come back to this slide, but I just wanted to give you the scope of the policy. And Michelle, I believe I sent you the actual copy of the organizational policy for the agency, and please send that, or I can put it in the chat at a different time. So you can, if you want to, if you're a policy wonk and you want to review all the components of it, that's great. We get next. Before even touching this slide, I just want to say that policy is very important, and I don't think we can ever overemphasize that. But perhaps even more important has been the principle of racial and intersectional equity in community organizing, right? So we want to make sure that the relationships that formulated that policy were cross-cultural, were rooted in lived and community experience, and that there was a strong power dynamic there to inform, shape, and implement the policy. And so I don't want to give the notion that we're just about changing the skeleton of an organization. We're trying to change the culture, a really balanced hearts, minds, and structural approach. This slide here is just a set of other kind of examples of REG and governance and how we're trying to apply it here in Minnesota. The DHS policy is what I highlighted here. And we can come back to this later, but I just want to give you a set of examples of how we're trying to embed it into governance policymaking. Next. I won't spend much time here, but I think this is another example of how the Biden administration has adopted an executive order on racial equity. President Biden has come out with 2 of these. I won't dive into them, but what I think is notable is that it has required many, if not all, federal agencies to come together. And what is significant here is, for the first time that I've seen, they've included national security, the National Security Council, MMB budget, and so they're adding different agencies that have been exempt or left off before, and so it just shows you the magnitude of the structural racism that I think is being assessed and addressed. Next. Yeah, I can't overemphasize this piece, because if we have folks who are working within the system, whether you're in a public health department or a health plan, again, I think it's really important for you to create those external allies. And this is a picture of me with our Lieutenant Governor, Peggy Flanagan. We're at the Hmong Village doing a mobile COVID vaccine clinic there. But in some situations, I'm very much the insider at Blue Cross, trying to change things within Blue Cross. And I know, Michelle, you asked me to talk about how change is different within Blue Cross and outside. And this is, again, profoundly obvious, but I have perhaps more safety and success picketing Governor Walz's office than I do my own CEO, right? But I can organize with advocacy groups, community groups, policymakers to make sure that I have the alliances that are necessary to influence Blue Cross effectively. So change occurs differently across different organizations, and then the inverse of that is true as well. And so if I'm part of the health plan, and I can help local governments or community groups, and so it's really important that you have that balance of inside outside solidarity and strategies. Happy to dive into what those tactics and strategies are later, but I think the broad principle of making sure that you're cross-cultural, interdisciplinary, and have those cross-sector partnerships in place. Next. And a lot of I think the task before us is to embed racial and health equity into our organizations, right? And again, I just want to make sure that there's a clear distinction and honoring DEI work, which is necessary, important, but I want to make sure that we're getting into power dynamics, into influencing the structure of an organization, from board to staff to partnerships to the way you do things. And so sometimes conventional DEI may not get at kind of those dynamics that are more ecological and that uproot power dynamics. And so I want to make sure that when we're looking at how can we apply this to commercial tobacco control, that it's not just about one dedicated funding stream, but it's examining who is within your team, what is their lived experience, what are their skills, how much money are you dedicating to this, how much oversight, that it really is about changing the engineering as well as the culture of your organization. And this is just a continuum of how organizations can transform themselves. And there are many models like this, but this is just one. And I think I sent Michelle this continuum as well too. So I know I may have gone over my time. I'm not sure, Michelle, but I'll we can go to the next slide, Joshua, and I want to make sure that we have plenty of time for Ladine, because I'm looking forward to hearing what Ladine has to say too. And maybe this is kind of a good capstone on my talk, and we can cover the rest in the Q&A. I just want to make sure that we recognize the importance of self-care, that's not selfish. I just came back from a 2-week time off from work, and so my mind is a little bit rusty and blurry right now, so forgive me if I'm not as coherent as I would like to be. And I just want to make sure that we're all of us in this work, we're not just doing kind of a 9 to 5, we're not just checking in and checking out, right? And so all these things are just good friendly reminders to connect ourselves to the people and the communities we love. I'll leave it at that, Michelle, and I'm happy to pass it back to you.
Thank you, Ladine, thank you, Vayong, for that wonderful overlay of how DEI and also equity can be embedded in organizations. I think once we hear Ladine's presentation, we can also get a little bit into the nitty-gritty of the different organizations and how to really implement those pieces. All right, now I'll pass to Ladine.
Thank you, Michelle.
Go ahead, take it away.
Can everyone see my slide?
Yes.
Can you see it?
Yes.
Okay, perfect. Thank you, Michelle. Thank you, Vayong, for that wonderful presentation. I appreciate that information that you share. I just want to thank Michelle Uphill for giving me this opportunity to really create a space to really share about the work around racial and health equity. Again, my name is Ladine Chan. I'm the program manager with Families Get Health at St. Mary Medical Center in Long Beach. Just a quick background about myself. I'm a 1.5 generation Cambodian American. My parents escaped the Cambodian genocide between 1975 to 1979. So I was born in the refugee camp of Kadak Dang between the Cambodian and Thai border. Came to the US in the early 80s, got sponsored by a family in Arizona, lived there for 1 year. And then we moved to Long Beach. We heard good things about Long Beach, the weather, the people. And so since then, Long Beach has been home for me. Long Beach is a great place. Been with St. Mary Medical Center for 18 years. I manage our youth development program, but also our chronic health prevention program, working with our Cambodian older adults on education, social support group, and enrollment. And again, my expertise is definitely around youth engagement, community organizing, policy and advocacy, and tobacco work. My topic is just really talk about St. Mary Medical Center, just really looking at the different programs that we have, and also looking at our community assessment, how we define community assessment, and then just really talk about the history of Families Get Health, just really the importance that we play in our community, and just then also talk about our past and present and future around the tobacco work that we have done. Again, I work for St. Mary Medical Center. In 2019, Dignity Health merged to Common Spirit. So now we're known as Common Spirit. So our mission is definitely as Common Spirit. We make a healing presence of God known in our world by improving the health of the people we serve, especially those who are vulnerable, while we advance social justice for all. Again, we're located in Long Beach, California. I believe it's probably the 5th largest city in California, the largest Cambodian population as well, actually. And we just celebrated our 100th year yesterday, actually. So we've been serving the community for 100 years. Again, St. Mary Medical Center is located in the 90813 zip code, which means a high-risk community of low income, poverty, homelessness, violence, and chronic health. The life expectancy is between 75 to 76.
Hi, Ladine. Sorry. Quick pause, transparent facilitation. Can you put your slides in presentation mode, please?
Oh, okay. How you do that? Sorry.
So you're sharing it right now. Actually, do you want me to share it on my end?
Yeah, please. Sorry.
No worries, no worries. Let me just take that from you. I got the power now. Gotcha.
Okay. So, sorry for the difficulty.
You got it. You got it. No
Okay,
worries.
next slide. Okay, so I'm going to talk about our community assessment. Our community assessments look at specific health condition behaviors and healthcare services, and also health-related social needs that have an impact on health and well-being. And so the 5 areas I'm going to talk about is, first of them is healthcare access, really providing financial assistance to those who have healthcare needs and are uninsured or ineligible for a government program. The next one is housing and homelessness, really being able to provide cash grants and outreach communication for a person experiencing homelessness. The third piece is really looking at mental health, increasing access to mental health services to community, and improving screening and identification of mental health needs. The fourth piece is looking at the preventative practices, providing healthcare screening, education, outreach to community at high risk of negative health outcomes. And lastly is violence and injury prevention, really looking at identifying patients who may be impacted by abuse, neglect, or violence, including human trafficking, providing victim assistance in a trauma-informed manner. So the 3 main program, so we have 3 different programs here at St. Mary Medical Center that really focuses on the community assessment, which I just talked about. The CARE program, Comprehensive Aid Resources Education Program, is a multidisciplinary HIV care and support program. The second one is the Low Vision program, which provide no-cost vision screen and optical aids and education referral for person with limited vision. And the third one is Families Get Health, which I work for actually. Again, I'm the manager with Families Get Health. We've been around since 1987, and our mission is really looking at we are a multilingual, multicultural health and social education organization that has culturally tailored programs for the Southeast Asian, Latino, and other community in Long Beach. Our mission is to help the community make informed choices and gain access to needed health and social resources. Again, Families Get Health got started actually during the Cambodian genocide. Again, like from 1975 to 1979, many Cambodians left their country and migrated to the U.S., especially to Long Beach. So during the mid-'80s, many Cambodians women were pregnant. So many of them did not know how to navigate like the healthcare system. Definitely there were a lack of translation, interpretation, resource, and materials not available. And so one of our board member, Gene Linsner, definitely rest in peace, was actively involved in the Cambodian community. And so he knew somebody at the United Cambodian Community. Her name was Lillian Liu, who was working there as well. And so she was involved in the Cambodian community as well. So he brought her on board to be the executive director. And during that time, we were known as Southeast Asian Health Project, now known as Families in Good Health. Since then, we have involved. We expanded our staff capacity and having different programs. Next slide. And so some of the programs I definitely want to highlight at Families Good Health is our Educated Men with Meaningful Messages, working with youth, really focusing on leadership development, social justice, and community organizing. Welcome Baby program, working with clients who are expected parents or parents with newborns and being able to navigate the early parenthood. Healthy Families America home visiting programs, working with the expected mom through the journey of pregnancy, continuing up to 3 to 5 years after the baby birth. And our infant massage workshop promoting, nurturing, touching through training and education. And our Cambodian community wellness program, working with our Cambodian older adults, conducting workshop on physical and mental health, providing social support group and wellness activity. And our benefits enrollment program, just working with our clients to help them enroll in different benefits enrollment programs such as CalFresh, Medi-Cal, and the low-income home energy assistance program. And lastly, our tobacco prevention program, working with the community to really support a smoke-free multi-unit housing here in Long Beach, but also really providing education on secondhand and third-hand smoke. Next slide. And so since then, Families Good Health has been working on tobacco work, especially working around Asian American, the community. So here are some data that show a wide range of smoking rates among some API community in California. According to the CDC, the percentage of Cambodian Vietnamese in California is very high at 35.4% among Vietnamese men and 24.4% among Cambodian men. The API community is very broad because of some group, the percentage is low. Next slide. I'm just going to speed up real quick. Long Beach has the largest concentration of Cambodian of any outside Cambodian. 4% of the Long Beach population made up the Cambodian community, and Cambodian town is 1.2-mile business corridor along the Anaheim Street between Atlantic and Wanapero. Next slide. The tobacco impact on Cambodian community. In 2011, 13% of the Cambodian Americans in Long Beach were smoker. Of those 13%, 24.4 were men and 5.4 were women. Next slide. And why is tobacco a problem in the Cambodian community? Cultural acceptance of smoking. Many of the older generation has been smoking since they were living in Cambodian, actually. Stress from social economic factors. It could be dealing with mental health, with jobs, family. Lack of education regarding dangers of smoking. Unfortunately, there's not a lot of education or resources available for our community. And just really the last piece is the lack of cultural tailored to tobacco cessation program. Next slide. And so some of the successes that we have done in the past with tobacco work is really having our youth participate in sting operation, really passing a policy on having a tobacco retailing permit, making sure that store retailers have a permit to sell tobacco. We also work on smoke-free Long Beach. So because of smoke-free Long Beach, we have a no smoking zone at beaches, park, and bus stop. We also helped pass a permanent flavored tobacco ban early in 2021. And we also have been doing work around smoke-free multi-unit housing and outdoor dining area in LA County and Long Beach. Next slide. And our success leads to partnership. Some of the partnership that we work with, such as Appeal, United Cambodian Community, Cal State Long Beach, really being able to strengthen our relationship and just really having them to really support our work. Next slide. Definitely youth engagement is very important to really engage our youth or our community members in tobacco work, just really having them have a voice in the community. Next slide. Workshop and training, just really providing different workshop and training for our youth to really learn about tobacco work. Next slide. Data collection. I think data collection is very important. We've been working with Cal State Long Beach, going door knocking, participating in different events, just really the importance of really collecting data in our community. Next slide. Community outreach. I think it's important to be very visible in the community, just really engaging with the community and just really sharing the different resources and information around tobacco work. Next piece, social media. I know social media has been something new for the past 10 years. So it's very important that we engage our youth and our members to really be active in social media, just really being able to share their story about how tobacco has impacted them. Next piece. And lastly, our city council meeting is very important to really build relationship with our city council meeting. So some of our youth were able to really testify, to really share the importance of having different ordinance here in Long Beach or different city in LA County, just being able to really help mobilize community members to really come together and have a voice, you know? Next piece. And again, lastly, these victories led to our success in really engaging and working with our community. We are continuing to work in Long Beach to really push for a smoke-free multi-unit housing ordinance. So yeah, so I appreciate the time for giving me this opportunity to really share about the work I do around tobacco work, but also how to engage our community members, our youth, and really pushing to help pass a policy. And so here's my contact information. And if you have any question, please shoot me an email and all that. Again, thank you. Thank you for your time.
Hey, thank you, everyone. Let's move on to the question and answer pieces. Some questions to start off with for both of you. What are some successful practices that your program has really implemented for policy change? And if not policy change, then community success? Ladine?
Ladine, I think you might be on mute. Ladine, yeah.
Can you hear me?
Yes.
Oh, best practices, definitely really engaging the community members, really creating a coalition, really creating a youth coalition and a youth program as well, just really being able to get them on board to really have them be the leaders in the community and have a voice, you know. I think it's really important.
Awesome. Vayong?
Yeah, I feel like I probably yeah, that I hammered this point, but I think the policy piece is key, just to make sure that the praxis of racial and health equity has a lock-in mechanism, right? That it's not just reliant on key people in positions of power or, you know, people turnover. Doesn't have the sustainability that we want. And then I would make sure that the policy has a companion implementation plan, right? So you see very much like, okay, assignments, timelines, investments, and that it's not just, you know, collecting digital dust, but that actually has real time and real-time power and longevity. So making sure that the policy has kind of the preceding community power to actually implement it, and then to have that implementation plan in place with accountability and teeth.
This question is specific for Vayong. Will you please speak to the shifting staff thinking about advancing an equity agenda? How can we move people from thinking in a traditional public health mindset of reaching as many people as possible to the need of policies that will benefit people in the furthest reaches of the margins?
I really love that question. And again, as a philosophy major, what you're bringing up is what I think is a mythology around health equity, right? That it is only a marginal benefit for marginalized communities, right? And in the language of public health, sometimes we'll use population health as justification to overlook health equity, right? And we often say the greatest good for the greatest amount of people. But if you're a Hmong or Cambodian refugee, you're never going to fit that formula, right? And so I think there needs to be you just need to do a gut check. And I'm not saying disregard changing hearts and minds. I just think that if we are reliant on enlightenment and consciousness, it's been over 400 years, right? And hasn't really gotten us where we need. And so I think that is the prompt for policy and systems change, so that you don't have to change individual minds and try to kind of just get this critical mass of thinking. I think that's where we need to really shift towards changing organizational behavior and impact, and bring hearts and minds along with. And so I think that problem that the questioner brought up is the very case for policy change. Yeah. So there are other strategies to change the narrative, to educate, all that. And I think we need to have that, but let's not rely on that.
These next questions, I think, are directed to Ladine specifically. How has the health system helped with multi-unit housing in Long Beach? And how have you tailored tobacco cessation programs to Cambodian and other ethnic groups?
Yeah, so we're in the works of really working with our community to really push a policy around smoke-free multi-unit housing in Long Beach. So at the moment, we're trying to build relationship with some of our elected officials to really identify champions to really support this ordinance. So we're we're trying to do more community outreach, more community events to really inform the importance of having smoke-free multi-unit housing. And what was the last question? Sorry.
Yes. How have you tailored tobacco cessation towards Cambodians and other ethnic groups?
Yeah, we're actually still working on that, actually, to really provide cessation program. So I know some of our staff have been trained in the cessation program. So just really being able to really coordinate some availability time to really provide those workshops for our Cambodian community.
Awesome. Next question, what are some barriers for policy change at a system level, and how do you work to build infrastructure to really get past this? And this is for both of you.
Barriers, I mean, broadly, I would say just the very definition of structural racism, right? And the denial of it. And a common response you'll get, or I often get, is like, well, we are already doing health equity work, or we don't need a policy. That's just a formality, or it's symbolic only, right? And I think that is, honestly, I think it's a cop-out. And if you're already doing it, why wouldn't you want to sustain, institutionalize it, have more impact? And so while you have support and champions in place, that is the precise time to lock it into policy change. And so I think it's really important for you to apply your external community organizing internally. So this is like advocacy 101, like who are your decision makers, create your internal coalitions, because ultimately it's not about just drafting a good policy. I mean, that's honestly the easy part. It's about creating the powerful alliances you need to actually accomplish and put that policy in place.
I think kind of want to add on to Vayong. very similar. I know there's some pushback from our elected official, just really having policy in place, having them have them write them out. I think that's important. I mean, I know it's been a struggle. I know with policy it takes a while, and so working with city council, definitely there's a lot of pushback, and being able to schedule ongoing meetings with them.
Awesome. This one speaks to specifically policy ownership. What does that look like? How do we build leadership authority and stakeholder power and accountability in an organization to really embed the equity work that you do?
I know we only have 2 minutes, so I'm happy to put my information there in the chat, or Michelle, you can send it out to have offline talks. I think within your own organization, I think one tactic that doesn't get used enough, I call it praising organizations into accountability. And there's a balance between being superficial and also just publicly stating and announcing a commitment, so that organizations may sometimes have to retrofit or backfill their health equity work, right? And so I think that's a tactic that we should all put into play, but I don't think that's the most powerful change lever, but I just want to name that. Getting your commitments out there loud, repeating that message, making sure everyone is known that your policy commitments are not kind of tucked away in a closet. I think it's really important that you can consistently communicate it, celebrate it, own it, and make sure that ownership doesn't reside just with an individual, but that it belongs to a set of decision makers, that it belongs organizationally, not just to a champion.
I think for me, I know we have 1 minute. Collaborating with different partners, collaborating statewide or nationwide, I think is really important to really get support from other folks to really help you to win different campaigns.
Okay, great. How do we also integrate that with community partners and also coalitions?
I spoke to this earlier, Michelle, but I think having that community connection built into the policy itself is really important. That it's not just kind of, again, a advisory group, right? Or that it's just kind of like some kind of key informant or some kind of info that is built into the power dynamic itself. I think that's harder for like private organizations like Blue Cross to do, because you're giving up and you're sharing power. But I think that is a very important aspect, so that you're not just exploiting or mining community for convenient input.
Yeah, just want to add on, just really building power with the community members, with youth, being able to really establish programs, to really establish coalition, to really have them take the lead, to really have them have a voice, to really help them push for policy.
And then 2 final questions from our audience. What efforts are going on to include LGBTQ and API folks in your tobacco control efforts?
Yeah, I think that's a really important one. In Minnesota, we have it's called the Minnesota Smoke-Free Generation Coalition. It's kind of like the mainstream one with Heart Association, American Lung, Blue Cross, and similar to my recommendations today, we've created a health equity committee, made sure that the composition of that coalition is ethnically, culturally diverse, that is inclusive of the LGBTQ plus and disability community, and that's built into the power mechanisms of the coalition, not just a component. But that's just, I think that's the template for other coalitions. Yeah.
Yes, and we have included the LGBTQT in our work as well. Just really being able to really support them, making sure that there's resources available for them and all that.
Awesome. And final question, do your programs utilize your state Medicaid community health worker benefit for tobacco-related community-based work? So Minnesota, South Dakota, Oregon, Indiana, Rhode Island, and now California have these programs.
That I'm not sure. I can get back to the question about that, but that sounds like a resource that shouldn't be underutilized.
Yeah, same here. I might have to get back to you on that.
Right. Appreciate the great discussion. I know we have gone a little bit over time, so I was just going to wrap it up. Josh, if you could put it on the last couple slides. So I really wanted to thank everyone for joining. For those of you who were able to stay over for the last few minutes, appreciate you for being here. Real quick, Appeal really provides technical assistance and training for communities and for states. This includes strategic planning, needs assessments, tools, leadership trainings, policy initiatives, and leadership development and equity-centered policy pieces. Next slide. Please do take our survey and let us know how we are doing, including our thoughts on our webinar. So you can go to either the link that I dropped in the chat earlier or use the QR code here. And be sure to check out our membership page and think about joining us as a member. So those two are linked as well. And finally, last slide. Thank you for joining us today. Find us on our socials. And I really wanted to take this time to thank Ladine and Vayong for joining us today for their great discussion on policy change in our organizational work. I hope this really, was something that was meaningful to you. And please do send your questions our way, and we'll try to get them answered for you. Hopefully, this talk will kind of help shape the policy pieces that you embed in the future for tobacco and tobacco-related cancer control. Thanks, everyone.
Thank you.
Thank you. Thank you.
Thank you.